Well
Sorry
done.
about that.
Well done, Rhonda.
I haven't-
Thank you, Laura. Great job.
I haven't moved as far in this event in my entire life. I don't know where I've been, anyway, I'm back again. So, well, we've fired on, Laura. Okay to fire on, is it? Yeah? I'll take that. We'll take that as a yes. We're going to go through all the talks one after the other here, and then have the questions at the end to try and catch up some time, if that's okay. So the first talk is by Ashish Godke, opioid-free and lumbar fusion surgery to enhance recovery.
Good afternoon to everyone. Myself, Ashish Godke, and I work as a spinal fellow at the Robert Jones Hospital Oswestry, and I have no disclosures to make. My topic is opioid-free analgesia in posterior lumbar fusion surgery to enhance recovery. The UK Office of National Statistics data published that the deaths related to just tramadol had increased to 240 per annum, and for the rest of the opioids were as follows. In 2015, for the first time, the crime survey for England and Wales included questions related to opioid misuse for prescription painkillers. But one may argue that these deaths are due to chronic usage of opioids, and how are they in any which way related to opioid consumption during a surgery? An article published by Brummett et al. In 2017 in the JAMA Journal stated that for many patients with a long-term misuse disorder, the first episode of opioid consumption can be traced to the perioperative period. Therefore, preventing the first episode of addiction is of paramount importance. Opioids have been a cornerstone of post-operative analgesia for many years. However, they are associated with many adverse effects that may prevent patient recovery after surgery. Surgeons and anesthetists together have opted many strategies to combat this epidemic, including ERAS pathways, which include multimodal analgesic regimen with non-opioid agents, spinal anesthesia, and regional blocks to control pain after surgery. On the contrary, spine surgery has always suffered due to the lack of regional alternatives and hence pain management post-surgery, and especially posterior spinal fusion surgeries. The authors of this study hypothesized that a low-dose spinal anesthetic combined with GA will reduce opioid requirements, enabling faster discharge from recovery, earlier mobilization, and hence a shorter length of stay. The purpose of this study was to evaluate an opioid-free anesthetic regimen and compare the perioperative opioid requirements with a matched cohort of patients managed with traditional opioid-containing anesthesia. We analyzed our prospectively collected data from January 2015 to December 2019, and in all, 66 patients were identified, of whom 26 had the opioid-free anesthetic regimen and 40 had the opioid-containing anesthetic regimen. The opioid-free anesthetic regimen patients had general anesthesia with low-dose spinal analgesic prior to induction, using 1 to 4 mils of 0.25% bupivacaine plus 0.2 milligrams of intrathecal morphine. By opioid-free analgesia, what we mean is that apart from the minimal dose of intrathecal morphine, no additional opioids were administered to these patients in the form of IV morphine or post-operative diamorphine or patient control analgesia, neither in recovery nor in the wards. Keeping the dose of the spinal anesthetic low, the assessment of motor function in recovery was not a problem. The opioid-containing anesthetic regimen patients had general anesthesia without any spinal analgesic, but with traditional intraoperative opioid analgesics like IV morphine in a dose of 0.1 milligrams per kg. So around 15 to 20 milligrams of IV morphine is administered routinely to these patients. And also in the recovery, these patients needed additional diamorphine for pain relief. Before the comparison, we used a covariate balancing propensity score weighted system to improve balance between the two groups. In the spinal group, the mean total perioperative morphine equivalent was 15 milligrams less, and the post-operative 48-hour oxycodone was 70 grams less. The mean length of stay in the hospital was found to be 1 day less, which is significant with regards to the financial implications on the bed cost the NHS must bear. VAS pain for recovery was 3 points lower in the spinal group, whereas the worst VAS score on day 2 of surgery was 0.8 points lower in the spinal group. The spinal group patients mobilized at a mean of 18 hours versus 32 hours for the non-spinal group. And all these results were statistically significant. Therefore, to conclude, as per Brummett et al. In 2017 JAMA Journal, for many patients with a long-term opioid misuse disorder, the first episode of opioid consumption can be traced to the perioperative period. Adding a spinal anesthetic to GA reduces the perioperative opioid consumption and hence helps in lessening the burden of the opioid epidemic. It helps in enhanced recovery after surgery with reduced pain scores, faster mobilization, a shorter length of stay, and hence reduced financial implications for the NHS, as it was seen in our study. Here are a few of my key references from the JAMA Journal, the Spine Journal, and the Perioperative Medicine Journal. Thank you.
Good morning, all. My name is Dheeraj Batheja, and I am working as a registrar in Robert Jones, an orthopedic hospital in Oswestry. Our topic for the day is minimal invasive lateral lumbar interbody fusion surgeries for adult spinal deformity patients, efficacy and complications according to MISLAT classification. As we know, adult spinal deformity surgeries are associated with a high risk of the complications, and Hans Rudolph, in the study published in 2008, showed 44% of a complication rate in adult scoliosis patient. Charosky and Rosoli et al. In 2012 published a paper with the overall complication rate of 39%. Similarly, Worley et al. Reported a morbidity from the deformity surgeries at the rate of 50.8% in around 12,000 patients. In 2013, Mumaneni et al. Came out with a MISLAT classification depending upon clinical and radiological parameters, wherein they divided the patients into 6 categories and suggested a sort of a treatment for each category. In our study, this is a retrospective study of 115 patients with 186 levels. All the patients were of the adult spinal deformities, being more than 50 years of age, with eldest being 94. Additional procedures were carried out in grade 5 and 6. Mean follow-up period was 21.7 months. This is an example of a MISLAT 3 where we can appreciate a reduction of elasthesis in a post-op film. This is a case of a MISLAT 4 wherein the scoliosis got better in a post-operative film with the maintenance of lumbar lordosis. This is a case of a MISLAT 5 wherein patient was operated outside the country and presented with a flat back deformity and a positive sagittal balance. This patient's main issues with the patient were radicular pains, and patient did not give consent for extensive fusion surgeries in the lumbar spine. Therefore, he had a breakdown of the fusion mass and T-lift to manage his radicular symptoms. However, he decompensated and required a further surgery in the near future. And in this film, we can see that his lordosis was maintained and it was comparable to a pelvic incidence. This is a 2-year follow-up film. We classified our data depending upon a MISLAT classification. This is a MISLAT 3 wherein we divided them into a foraminal stenosis with listhesis and without listhesis. And in the patients without listhesis, we used a disc height as a measure of indirect decompression. In MISLAT 4, we divided them into a segmental lordosis and segmental scoliosis depending upon the kind of a deformity they had. In MISLAT 5 and 6, patients were divided into a more global parameters, these being more global deformities, and lumbar lordosis, pelvic tilt, and scoliosis was calculated in these patients as well. Overall complication rate was 9.3% in MISLAT 3 category, 26.6% in MISLAT 4 category, and 38.1% in MISLAT 5 or 6 category. Overall complication was 19.13%, highest being in MISLAT 5 and 6 category as expected. 11 patients had a revision surgery within 1 year of an index procedure, and 1 patient died from pulmonary embolism. To conclude, authors feel that MISLAT classification is an effective tool while planning for the surgeries. It has a role at the time of consenting with respect to the complication rates, and also can play a role in medical legal purposes. Our study showed a
Our study
favorable
showed a
clinical and
favorable clinical
radiological results using minimal invasive lateral interventions, lower complication rates as compared to posterior surgeries. However, medical complications cannot be
complications
prevented by
cannot be
MIS
prevented by
surgery.
MIS surgery.
Reoperation rate in our study is low, probably reflects the lesser severe deformities we tend to use using a minimal invasive surgeries. This classification and this form of a treatment has definitive use in elderly age group patients as well. Many thanks.
Many thanks.
Thank you.
Thank you.
Thank you very much, Dheeraj. Our next talk is from Jake McDonald, Risk Factors for Distal Junctional Failure in Long Construct Instrumentation for Adult Spinal Deformity.
Hi everyone, my name is
Hi
Jake
everyone, my
McDonald.
name
I'm
is
a
Jake
final year medical
McDonald. I'm a
student
final
at the
year
Royal
medical
College of
student at the
Surgeons
Royal
in
College of
Ireland, and today I'm
Surgeons in
going to talk
Ireland.
about
And today
risk
I'm going to
factors
talk
for
about
distal
risk
junctional
factors for
failure
distal
and long
junctional
construct
failure and
fixation
long
in
construct.
adult spinal deformity. So as we know, ASD represents a great surgical challenge for practicing spine surgeons, and this is due to its potential to present with a multiplanar deformity, often requires long construct fixation and is associated with a high complication profile nonetheless. In comparison to its counterpart, distal junctional failure has only relatively recently been recognized as its own entity, and the precipitating risk factors are therefore poorly understood, with only 2 studies to date in the literature that actively look at risk factors for DJF. So that's sort of the premise for this study, which is a retrospective review carried out in a collaborative manner between the Rotman Institute in Philadelphia and the National Spinal Injury Unit in the Mater Hospital in Dublin, looking at ASC patients that underwent long construct fixation to the pelvis to collate and compare demographic, clinical, and radiological characteristics, with the primary aim of identifying risk factors associated with DJF, and the secondary aim of assessing the incident rate and the cause of pathophysiology. So we identified 102 patients, and of those 102, 41 cases, which represents 40% of the entire cohort, experienced DJF in the postoperative period. The majority of our patients were surgically managed with circumferential fusion with S2 AI screws using an interbody device, with ALIF being the preferred method. In regards to the causes of DJF, there were 65 causative factors noted across the 41 patients. Screw halo was the most common cause, with the other ones being listed in Table 2. Interestingly, the mean time to failure was 32.4 weeks, and another interesting thing to note is that many patients actually experienced 2 or greater causes of failure, again listed in Table 2. In terms of the comparative demographic and clinical characteristics, the significant parameters on regression analysis were the performance of a pedicle subtraction osteotomy and the performance of a transfemoral lumbar interbody fusion. It's worth noting that although ALIF appeared statistically significant, this result was in favor of no DJF, and thus ALIF may prove a protective factor against the occurrence of DJF in long construct fixation for ASD population cohorts. Again, we looked at all spinal parameters, and without going through them all in detail, you see the significant ones listed on the left-hand side of this graph. And there's a great variety between the preoperative, postoperative, and overall correction of spinal parameters, with 10 statistically significant parameters in total. So of those significant parameters listed on the previous couple of slides, we put them all into a multivariate analysis. And what we saw is that on multivariate analysis, pedicle subtraction osteotomy, postoperative SVA, and the overall correction of lumbar lordosis all retained their significance as influential risk factors for DJF. We also went a couple of steps further, and we performed a Spearman correlation analysis on the significant spinal parameters to try to understand if those with greater residual spinal malalignment in the postoperative period were more likely to fail sooner, and no significance existed for either lumbar lordosis or for sagittal vertical analysis, but it was an interesting thing to note. So in discussion, again, as I previously mentioned, there is a great paucity of evidence that directly investigate the risk factors for DJF. 2 studies to date, Flaccari, who looks at the pediatric population, and Cho, who looks at an ASD cohort. And we shared some similarities with Cho in that there was a poor correction of SVA, and he also noted a poor correction in lumbar lordosis, pelvic incidence, and lumbar lordosis. However, the one strength that our study has over Cho is that he was limited in the univariate analysis, while we went on and performed a multivariate analysis. Other things in the literature that are interesting to take into account are that Barton and all postulate that it's actually undercorrection of deformity that can lead to post-operative functionality, and a couple of other authors support this theory, reporting that it's residual kyphosis which precedes loosening and failure of instrumentation at that distal junction, which is what we saw in the poor correction of lumbar lordosis. And additionally, LeHook and al., which had a study of 63 patients, also noted that PAO highlighted residual spinal malalignment secondary to the undercorrection of curves. So performing a PSO and still failing to correct that spinal malalignment can again precipitate a great degree of mechanical complications. So in conclusion, risk factors for DJF and ASD cohort are polarly understood. 40% of our cohort suffered DJF in the post-operative period, and it was the performance of a pedicle subtraction osteotomy and failure to restore satisfactory SVA and lumbar lordosis parameters that were statistically significant risk factors that influenced the occurrence of post-operative DJF. Thank you.
Okay, can I introduce the next one? Cornelis Polstra, retrospective evaluation of spinal fusion using a biphasic calcium phosphate bone graft with a novel submicron surface topography. Bit of a mouthful.
Good afternoon. My name is Cornelis Polstra, and I am just starting out in Las Vegas at the National Robotic Spine Institute. We're going to talk about real-life clinical data in the cervical and lumbar spine utilizing this really unique submicron topography, beta-calcium phosphate. My study setting in the cohorts, this was gathered in rural Northwest Florida when I worked there at the Spine Institute on the Emerald Coast, as some of you guys may have known. This is like a real-world patient population, right? All comers and a consecutive series. So the methods here for the cervical spine first, 25 patients, 80 fusion levels total, mostly anterior standalone, except for 3 patients where I did a front back, as you can see there. Mostly simple degenerative myeloradiculopathy, some kyphotic deformities that needed to be corrected. 38 fusion levels were in 1 or 2 level cases, 42 fusion levels in 3 or 4 level cases. And post-operatively, the evaluation was done with standard flexion extension radiographs, and CTs were only really gathered when needed. We had some validated outcomes measures, but there were a lot of holes in this. So eventually we grouped all this together in a Prolo scale. So Prolo scores are reported eventually for patient improvement. If you look at the lumbar series, we had 52 patients, 97 fusion levels, anterior reconstructions with titanium-like cages, as you can see above there, with the bone graft placed inside of it, with a posterior tension band recreation. Simple degenerative to sometimes really complex cases. More than 60% of the surgeries were revisions. 60 fusion levels had 1 or 2 level anterior interbody cages, and 37 of the fusion levels had 3 or 4 level cases. Evaluation was again done with FlexX radiographs as well as CTs when needed. And we were pretty aggressive with the indication to get this if patient did not progress clinically like we anticipated. Again, Prolo scores were reported for improvement. This is an example of how the bone graft was utilized. It was mixed in specific ratios with morcellized allograft cortical fibers, and then some bone marrow aspiration was utilized to mix it together into a paste. So results, of course, fusion was our primary endpoint, and in the lumbar spine cohort, 94 out of those 97 levels fused reliably. As you can see on the solid A picture on the left there, this is above a prior like screw-in cage, right? As you can see at the bottom, those 2 levels are solidly fused. But on the right side, we see some subsidence in the superior end plate of that vertebral element, as well as some lucency, and we categorize this as a pseudoarthrosis. In the cervical spine fusion category, 75 out of 80 levels fused, so a 94% fusion rate. All pseudoarthrosis were in the 3 and 4 level standalone cases anteriorly. And as you can see here, this was a patient who happened to have a motor vehicle collision and had a CT scan of the cervical spine. And you can see the fusion is very nice through the titanium cages. So anybody who says that you can't really evaluate fusion through titanium, I don't necessarily agree with that. I think if you do a good job with windowing the images and you look at multiple sequential coronal and sagittal cuts, it is not that hard to see a pseudo over a solid fusion. For both groups, importantly, there were no infections and no graft or implant-related side effects. And if we look at the outcomes, then this modified Prolo scale, and you can see the reference attached there, had a significant improvement from initially 11 to 16.1. The highest score you can have is 18. So this showed a 46% improvement in the lumbar group, and a similar improvement of 48% was seen in the cervical group. And there were only 3 out of all of our patients that had a inappropriate amount of improvement and rated their results as fair postoperatively. However, all the other ones rated it as good to excellent. What is important to say, I think, is that a minimally clinically important difference in both groups was reported more than 95% positive of patients showing clinical improvement here, and that the fusions that we noted within 6 months in both groups exceeded 75%. In summary and discussion, I would say, this is real life data, right? Real life patient cohorts for cervical and lumbar reconstructions. And I'm pretty proud of the reliable fusion rates we were able to show very early on already with this novel biphasic calcium phosphate bone graft with a surface topography that's very different and unique, right? And I think it's distinctly different from what I sort of jokingly call like those other white granules, right, that are getting sprinkled onto the back table. I think it's important for you to understand that there is a difference between the early generation white granules that are on the left side there on SEM images towards all the way the right side, the material we utilized, because we now know that by modifying the surface, we can induce a unique biologic response from host bone and host cells that come in contact with this material. And we're able to upregulate now what we call macrophage phenotype M2, which is a pro-healing macrophage, as opposed to the other white granules that upregulate the M1 macrophage, and that's actually a pro-inflammatory macrophage. So along with this, positive radiographic result, there were positive patient improvements in the proto scale, and there were no bone graft or device related complications. I hope you have a great weekend, and thank you very much for having me.
Thank you, everyone. Are all the speakers present for questions? Yeah. Can I just start off with the first question for the first speaker, Mr. Kodke? I know in your institution, it seems to be that this postoperative pain is being looked at quite closely. Have you looked at using ketamine infusions on your patients, and does that make any difference? Ashish Kodke, can you guys hear me?
Yeah, we can hear you, yeah.
Okay, so if Ashish is not present, then I've got a question from Jake McDonald. The question is for Cornelis.
Oh no, sorry, I jumped the gun on that. Cornelis actually answered my question throughout his presentation.
Oh, okay. Any other questions now?
Okay, so let's ask Dheeraj a question. I'm not familiar with this classification, to be totally honest. Does it help plan the surgery, do you think? Is it any good for prognosticating of what we do?
Sorry, you may be mute at the moment.
I think you're muted.
Can you hear me now?
Yeah.
Okay, so from their paper, they have just given a classification and based a treatment on that. What sort of a treatment patient would ideally be given based upon where he falls in the classification system. But in our series, we found out, as expected, misled 5 and 6 have got more problems and more complications as compared to a lower degrees of deformity, more localized deformity as we see in misled 3 and misled 4 classification. This classification came in 2013 and yeah, it's a good way of classifying the patients, especially for those who are new to the minimal invasive surgeries and expect what sort of a thing you can do for the patient by just doing a minimal invasive approach. Also, even when you are doing a misled 5 and misled 6, which means there's more global deformity, what we tend to do is we use this minimal invasive approaches in a form of a lateral approaches in X-lifts and minimal invasive A-lifts, and then see how much patient has regained with respect to his overall sagittal alignment, his PI-LL mismatch, and then if needed, we go in posteriorly and do a proper open osteotomy, depending upon how much more we need to gain in that patient. So that becomes a stage 2 of a surgery if needed.
Brilliant, thank you very much. Jake, can I ask what stage are you at, Jake?
So I'm a final year medical student.
Well, high comment, amazing respect for the presentation you gave, given that. I struggle to understand those concepts, so hearty congratulations. You may not be able to answer, but I'll try. Did you say that really the degree of poor alignment, if you like, doesn't correlate with the complications? Is that what you were saying?
No, so it does to a degree. So on our analysis, what we saw is that poor post-operative SVA, which is really, we know, is a non-specific parameter in a lot of complication studies that you look at for spine surgery. But it was really a failure to restore a satisfactory lumbar lordosis that we believe in theory will contribute to mechanistic stressors. And there's a couple of studies in the literature, like the LeHook one, that really pointed at that when you're doing a taxiing procedure like a PSO and you still fail to restore lumbar lordosis, that can really precipitate mechanistic stress in an unequal distribution. And a lot of that we think points to the fact that a PSO may not be performed at the right level for a lot of these people. And we know at L3 it might be technically more feasible and easier to do, but we know that the apex of the deformity could be L4 or even as low as L5. So it might be a case of, in a prospective manner, being more considerate about what level you decide to perform a PSO at.
Your answers blew me away, Jake. Finally, a medical student, I was astounded.
I've got a lot of great mentors, so thankfully enough they're rubbing off on me.
I've got a question about the MISLAT presentation, if I may. You showed a picture of a single level PLIF with reduction. Do you consider a single level spondylolisthesis as a deformity, and do you then aim to correct all the parameters, not just the reduction, but also all the angles?
Yeah. So if I can go back to that classification, you would see on the basis of a radiological parameters, MISLAT single level would not go into where they have a global parameters deformed. Mostly they would have within normal limits their lumbar lordosis and their overall PI-LL balance or mismatch. It's just that at a single level, they are either listhesed or they are just probably a segmental kyphosis or segmental scoliosis, some sort of that parameters comes in. And then we just address that level. If they have a more of a global imbalance, they have a positive sagittal balance, or they have a basically high PI-LL mismatch, then they would subsequently be classified into MISLAT 4, 5, or 6, and then they would require a more extensive surgery than just a single level.
Thank you. I think maybe that's time, Raja. I think we're out of time here. But thank you very much, everyone, for a great session. Everyone, it's lunchtime in the auditorium.
Right. And I think Ashish has answered his your
he has, yeah.
Well.
Yeah, he has. Yeah.
Please don't forget to visit the sponsors. It's really important that we support them as they're supporting the conference.
Thank you.
Yes, thank you.
Thank you, everyone.